What I will deal in the next minute is first an historical overview of ventilator-induced lung injury, and by the way, I will mainly talk about VLI in the context of ARDS. Then some clinical perspectives, and at the very end, a few concepts that I think might be viewed as new. This is the starting point for the history, if we wish, of ventilator-induced lung injury, and is a conceptual starting point. These were the time when ARDS was considered a bilateral homogeneous injury of the lung. It was at that time known that ventilator could bring injury. At that time, injury was pneumothorax, basically. A major change of thinking came upon when the CT scan was brought into ARDS. At that time, the philosophy changed dramatically, and it was clear that it was not yet an homogeneous injury, but dishomogeneous. And this led to the perception that tidal volume in this very tiny lung, these were times where the baby lung concept was brought upon, was clearly a problem. Lung protective ventilation strategies became very important, and 1998 to 2000, there were lots of investigators that were working on tidal volume reduction as a means of improving outcome based on that knowledge. And as you know, we've heard it several times, the ARDS network brought clearly and has a landmark paper in mechanical ventilation in the ARDS patient, the concept that too much volume is dangerous. The investigations were very similar among them, yet only one was positive in its result, and this led to some discussion on the mechanism. Why is your positive and mine is not? At that time, and still right now, to be honest, there are two main views of ventilator-induced lung injury. One is alveolar overdistension that you can see at the very high level of inspiratory volume, and these are probably the landmark, at least what I feel are landmark papers and prove this concept. And the other concept is tidal breathing collapse. We've talked about this in this session, in this meeting, opening and closing of alveoli over respiratory cycle. As I told you, at first ventilator-induced lung injury was macroscopic, was pneumothorax. Then it became more subtle as a definition. Microscopy came in, highly membrane formation, neutrophil infiltration was part of the definition of ventilator-induced lung injury. Parker mainly brought upon the concept of coefficient of filtration, therefore permeability changing, albumin space, this was time of Dreyfus, and the biotrauma then concept came on. I was lucky enough to be part of the project, and at those times we were ventilated, isolated lungs, they ventilated them with very aggressive ventilation, and as you see, this was the high volume and zero PEEP group. There was a huge shift to the right of the pressure volume curve with an inflection point indicating major injury, and this was the scenario that at that time was pretty new. Bronchoalveolar lavage was filled with a much higher level of cytokines, which was, again, a new concept. And the first thing we asked ourselves was, is this simply lysis? Are we breaking down the cells? Or are we triggering a response of the cells? And basically, the idea was, if there is an adaptive response, then DNA, mRNA, protein synthesis was the factor leading to the gene induction, therefore those cytokine release, and in fact we proved that it was mRNA, and therefore that was the case. And this was subsequently confirmed in a clinical setting a couple of years later from Marco and his group, where they were able to show that in fact the protective ventilation strategies was able to reduce inflammation. So basically at the time there was the concept that yes, lung is injured by the mechanical ventilation. There is a biotrauma. This was a fantastic paper, Charlie Bryan's group, in which they found that if they ablate neutrophils, there was not injury. Following this, it came a number of papers in which it was clear that not only the lung was injured, but you could find something in the blood bringing to the concept of loss of compartmentalization, as it is called. And this is where the distal organ hypothesis of Art Slutsky's came across, basically suggesting that since patients in the intensive care do not die hypoxic, rather they die with multiple organ dysfunction syndrome, maybe ventilator-induced lung injury is the link between the two. When I came back to Italy, I did some work on this, and we proved that kidney injury is there. Yumiko Imai, a few years later, proved that, yes, the kidney is affected differently according to the strategy of mechanical ventilation. And she proved that, in fact, apoptosis was much higher with injurious ventilation. Yet, the question was, is it barotrauma? Is it volotrauma? And for a certain amount of time, this was an important element of discussion, which clearly came and was pushed in a way from the fact that the positive study was the one that was mostly separated in terms of volume, bringing to the concept of, again, volotrauma, and based on the science, the Dreyfus paper, this is a landmark paper, in which he showed that if you ventilate with high volume or with high volume and low pressure, or with low volume and high pressure, and he did this stripping the rib of a rat, basically he showed that it is the volume, and this was the reason why we still talk about volotrauma. However, volume and pressure in the lung, by definition, go together, and we tried to reconcile these two positions, and some physics help. If you consider a solid and you apply a force on the solid, this will lead to a certain amount of stress, which is the force divided by the surface. But if the solid is allowed to elongate, to change its length, then what you're doing is you are straining the solid itself, meaning that you are changing somehow its length from the starting length. And translated into our ventilator-induced lung injury system, theoretical and practical actually system, this stress concept translates to transpulmonary pressure, and the strain translates into the tidal volume distribution into end expiratory lung volume. Antonio talked about this yesterday, and these are important concepts, which could be, in a way, viewed as barotrauma, volotrauma, which in fact we believe are the two faces of the same coin, and this was proven by Davide Chiumello, who showed that strain and stress do have a straight linear relationship, which is based on this K, which is specific elastance. And again, Antonio talked about this yesterday. Now, if you go down to a local level, rather than the entire lung, and you think of the lung as a net of alveoli, clearly, if you inflate this, which is an homogeneous lung, you will have homogeneous inflation, as opposed to what would happen if the lung was not homogeneous. If there is something that is not expanding, whatever is close to this will expand much more. Therefore, you will have local stress, and at the cellular level, this has been very well shown to be a problem. Macrophages, endothelial cells, epithelial cells, when stretched, they do react with inflammation. And if you stress them too much or strain them too much, they just die. So this is an intriguing, important concept that need to go along with this one, which is very important in its essence. This is just one of the papers showing that if you strain or ventilate a lung after priming it, then the response of the lung is much different. This is important. This is an important concept. What about clinical perspectives? Now, if we take the barotrauma and volotrauma perspectives and start with the volotrauma, implying the distribution of tidal volume into the lung volume and the expiratory lung volume, then, and I already said the key word, we are talking about distribution of ventilation. Now, what can change the distribution of ventilation? Clearly and certainly positive end expiratory pressure. And we have proven that in ARDS patients, when you add positive end expiratory pressure, you distribute in a more homogeneous way the tidal volume within the lung. Therefore, strain is lower. There are lots of demonstrations that positive end expiratory pressure is effective in preventing injury. This is the study by Mushedere, which is an important one, in which he showed that if you ventilate just below or just above inflection point, things change much. This is, in fact, a classical view of an investigation on Vili, where you ventilate with strategy A and B, and at a certain time you close the experiment and measure the amount of injury. We have turned this and flipped it around, and we said, well, maybe if you ventilate up to the point when you reach a constant injury, you can, at this time, use time to need the injury as your outcome, which in a clinical way is as saying, by this ventilation, I am buying time rather than I am not doing harm, which is, to me, philosophically very, very different. And we've proven with the positive end expiratory pressure that, in fact, yes, this is the case. So there is basic science proving that PEEP is useful, but the paper came out where there was not significance. And this was somehow astonishing in the intensive care community, because everyone knew that it was working, and everyone was, in fact, using PEEP. And if you go back and see 1972 Pontoppidan, impressive changes in PO2. Simmons, 1979, impressive changing in shunt, something that people was seeing. This generated a sort of debate on, wow, what is happening? Why is this happening? That we are lucky enough to have reconciled, probably by means of this meta-analysis, in which it is clear that the sicker the patient, the better the efficacy of the PEEP. Prone positioning is another way of improving distribution of ventilation. This is another important concept that probably comes much earlier than the PO2 itself. We have worked on this in animals, and we did CT scans and proved that in supine position, the distribution of tidal volume, this is end expiratory, this is end inspiratory, is mainly where you expect it to go. And it is pushed towards the base in prone position. And again, this is associated with a much more homogeneous distribution of ventilation that goes along with ventilator-induced lung injury reduction with our system of the timing. Similar to the PEEP story, a number of trials have failed by themselves to prove that prone position is efficacious, but this standing for the subgroup of very, very sick patients below the FiO2 of 100 was, again, and we have heard this earlier, this is a setting where prone position is efficacious. And probably, this is my feeling, more on the ventilator-induced lung injury rather than the PO2 itself. What about stress, the other side of the coin? If you think of transpulmonary pressure, then you know that you need to measure esophageal pressure as opposed to pressure, airway pressure alone. And this is the basis. If you want to know transpulmonary pressure, you need esophageal pressure because this is the relationship. And again, you saw this earlier. This is much important in every setting in which the chest wall compliance is either unknown or is changing. And this is important because if you draw this line, tidal volume, transpulmonary pressure, and plateau pressure, and you imagine to increase plateau pressure, airway, PAV, P-A-W only, yet transpulmonary pressure will change dramatically according to the relationship of the elastance of the lung in comparison with the total elastance, such that, for instance, if you consider this as a safe threshold, you can ventilate at 6 ml per kilo in a very safe way or in an almost dangerous zone. This pushing to the concept of the need to use esophageal pressure that has been brought upon by Talmor that showed this significance almost of 28-day mortality when using esophageal pressure to titrate PEEP, so with this concept of transpulmonary pressure or without. There are backdrones, if you wish, of using esophageal pressure. This is the paper in which we were investigating this, and we were inflating the abdomen of a pig. And as you see, esophageal pressure does not change at end expiration. However, it increases at end inspiration, pointing to the fact that one thing in using esophageal pressure at end expiration, probably you want to use this if you are thinking of an absolute transpulmonary measure, and different is using changes in esophageal pressure that occur when the chest wall is changing. So from a clinical perspective, baro and volotrauma, at least the way I see it, are not really different. What matters is transpulmonary pressure is one way of seeing baro, and VT over end expiratory lung volume is one way of seeing volotrauma. And just quick concept on something that supposedly new but not, meaning signal transduction. This is a cartoon showing all of the possible pathways that are implicated. In this case, these are endothelial cells in the increased permeability during mechanical stress. This is one point. But there is a whole gene ontology in acute lung injury and in ventilator-induced lung injury. And these are all areas that are under investigation. Signal transduction, for instance, is one of that Marco is investigating and showing that there is the potential to work as deep as that level of signal transduction to modify and work on, in this case, this was lung edema, and they were knockout PI3 kinase gamma mouses. Recently, we have faced a new concept, which is, to me, very interesting and important, and is the paper by Dos Santos, in which she showed with a number of interesting evidences that there is a neuroimmune modulation that can contribute or modulate ventilator-induced lung injury. And this is something very important, and I think we will face this and be interested in this as well. In conclusion, therefore, again, transpulmonary pressure, VT over end expiratory lung volume, the way you want to see it. But to me, the important is, at least in difficult cases, measure whatever you like, the transpulmonary or you like the volo system, but this is something important. Probably there are new potential targets that we will be investigating in the future. And the very novelty probably is this one, which is provocative, and I refer to Antonio's talk of yesterday. Thank you very much.